Welcome everyone to today's session of the Neuro-Oncology Wellness Program educational series focused on brain tumors, led by the NOW team. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the NOW program for this continued partnership. The recording of this session will be posted on our Blum YouTube playlist, as well as our Blum Digital Resource Center. For those of you watching live, if you have any questions related to today's program, please feel free to utilize the chat feature or the Q&A feature throughout the session. At the end of the session, we will use your questions in the chat to moderate a Q&A. If you have any questions or would like more information about resources and programs offered through the Blum, please visit our website at www.dana-farber.org/resource center, or you can email us at blum_center@dfci.harvard.edu. Thank you all for joining us. I will now pass the workshop over to Rachel Fox.
Welcome everyone to our inaugural Neuro-Oncology Wellness educational webinar on brain tumor symptoms. The Neuro-Oncology Wellness, or NOW program, is a new initiative from the Center for Neuro-Oncology at the Dana-Farber Cancer Institute, with a mission to educate patients and their caregivers about brain tumors, as well as provide resources to promote overall health and well-being. My name is Rachel Garcia Fox. I serve as the program administrator for NOW, and I'll be your host for this series. Before introducing our speakers for today, I would like to introduce Dr. Gonzalez Castro, the director of the NOW program, who will provide a brief overview and discuss upcoming offerings.
Thank you so much, Rachel, for the introduction. We're so excited that all of you are joining us today. And I want to start by thanking Dr. Lee and Dr. McFaline-Figueroa, who will be discussing brain tumor symptoms with us today. But I wanted to take just a few minutes to tell you about the Neuro-Oncology Wellness Program and what the program aims to achieve. We're hoping to provide comprehensive support to our brain tumor patients and their caregivers. You know, the efforts at the Center of Neuro-Oncology are focused on clinical care. You see us for an hour, half an hour, every so often when you come to our center, and we address the management of your specific diagnosis. But we realize that there are hundreds of hours that you're not with us, and in which you probably have questions about how to best optimize your life to live with your diagnosis and to achieve the best possible outcome in terms of your function and your interaction with others. So with that goal in mind, we are developing resources regarding patient and caregiver education. And this is an example of that, this offering that we have today, as well as a number of offerings that you'll be hearing about improving physical and emotional health in all of our patients. Lastly, we want you to be able to connect with other patients and other caregivers if you want to do so, because the experience of living with cancer diagnosis can be very isolating. And there are so many questions and so many benefits to be gained from interacting with others that we want you to join our support groups and be a part of it, to take lessons from other patients and also to share your experience with others. Briefly to summarize, we're having the webinar today, and there's going to be another one in a month on the topic of glioblastoma. The following month, we're going to have a webinar on isocitrate dehydrogenase mutant gliomas, IDH mutant gliomas. In September, we're going to have another webinar on central nervous system lymphoma. In October, we'll be tackling brain metastases. And then we will close the cycle for this calendar year in November with a discussion on clinical trials in neuro-oncology. Also, be on the lookout for our exercise for brain tumor patients course. We'll be discussing what is exercise and how it should be implemented in patients with brain tumors, and what are the benefits we should expect in terms of benefiting our overall health, as well as our survival with our diagnosis. And in addition to that, we have our brain tumor support groups, both for patients with low-grade gliomas as well as patients with high-grade gliomas, that we hope you will join. So we hope that you will be part of the NOW program, a program that is designed for you and is designed to help you implement strategies to live better now. And that is our email address. And if you have questions about our program, or want to join our email list, I ask you to just email us at that email. Thank you so much.
Thank you, Dr. Gonzalez Castro, for that exciting overview. For today's webinar on brain tumor symptoms, I'm delighted to introduce Drs. Lee and McFaline-Figueroa. Dr. Lee is the Director of Clinical Research at the Center for Neuro-Oncology and Associate Professor of Neurology at Harvard Medical School. Dr. Lee also serves as Director of the Mass General Hospital Dana-Farber Cancer Institute Neuro-Oncology Fellowship. Dr. Lee is a recipient of the American Academy of Neurology Young Investigator Award and has been involved with translational neuro-oncology research for over a decade. Dr. McFaline-Figueroa is a physician scientist at the Center for Neuro-Oncology and an instructor of neurology at Harvard Medical School. Dr. McFaline-Figueroa is the recipient of multiple teaching and research awards. He is currently leading several clinical and basic science efforts to improve targeted and immune therapy approaches for the treatment of glioblastoma. Drs. Lee and McFaline-Figueroa, thank you for joining us. Before we start, I want to remind our live audience that we want you to be a part of this conversation by submitting your questions via the Q&A feature at the bottom of your Zoom screen. We'll select a number of your questions for our guests to answer in the second half of the program. Please also note that we'll only aim to answer questions relevant to today's topic, brain tumor symptoms. And additionally, if you have any questions related to your health or a loved one's health, we encourage you to seek out advice from a medical professional. So the words brain cancer evoke very frightening thoughts in the minds of many individuals, and it's not uncommon for people to think that they could have a brain tumor in the presence of certain symptoms. Dr. Lee, how common are brain tumors, and what are their usual presenting symptoms?
So first, let's start off by defining what brain tumors refer to. So these are, as the name suggests, tumors that we find in the substance of the brain. Now, there are tumors that arose in the brain, and those are called primary brain tumors. Primary brain tumors are relatively rare compared to other kinds of cancers like breast or lung cancer. There are about maybe 15,000 new patients diagnosed per year in the United States. The estimates vary depending on the kind of brain tumor, obviously. But the most common type of brain tumor that we actually see are brain metastases, which is the subject of a different topic on a different day. But those are tumors that have arisen from a cancer that started somewhere in your body. So like a breast cancer that went up to the brain, or a lung cancer that went up to the brain, for example, those are called brain metastases. And the incidence of those are not clearly known because we don't do such a great job of collecting that information across the United States, but it's estimated somewhere between 100,000 and 300,000 patients per year are diagnosed with brain or have brain metastases.
And what are the usual presenting symptoms for brain tumors?
So this entirely depends on where in the brain it's located. Do you have one lesion? Do you have multiple lesions? How quickly did that lesion develop and grow over time? As you can imagine, a slower growing tumor might not be associated with any symptoms, or a tumor in a part of the brain that is not that does not contain important function might not have a lot of symptoms. But some of the symptoms that could potentially suggest that something's happening in your brain, which could be a brain tumor, are what we call focal neurologic deficits. So if you develop weakness on one side of your body, if you develop seizures when you've never had seizures before, if you develop severe headaches when you previously were not a person that had headaches before. So new symptoms that could potentially be referable to the brain could potentially be associated with a brain tumor, but of course, many of these symptoms can occur as a result of other issues involving the brain. So there's nothing specific per se.
Thank you for that overview and comprehensive answer. Dr. McFaline-Figueroa, let's focus in on headaches a little bit more. Do headaches associated with brain tumors have any specific features?
Hi, thank you for having us, Rachel and Dr. Gonzalez Castro. Yes, so there are, as Dr. Lee mentioned, the majority or a lot of these symptoms are non-specific, and honestly, most cases of headaches in the general population are benign, right? So most people have tension headaches or migraines or stuff like that. There are a few signs that clue us in to the possibility that it could be a brain tumor related headache. And so most of those symptoms have to do with the fact that because brain tumors take up space and push the normal brain, you can develop symptoms through that mass effect. So the most common ones are nausea and vomiting that's severe. And you can get that with migraine, but here, this usually kind of a more escalating type of nausea and vomiting. You can also have issues with where the pressure is so high that it might cause things like confusion. For most brain tumor patients, or not for brain tumor patients, sorry, another warning sign that the headache might be related to a brain tumor is if there's neurological symptoms. So for example, someone who's developing headache, but also feels like their right arm is progressively getting weaker or more numb. It's not perfect, but some brain tumor patients describe that their headache is just worse in the morning, or when they're doing an action that increases their abdominal pressure, like bearing down. And that might mean that in those situations, the pressure of the brain gets even higher because you're lying down on the pillow or because you're doing force. And that characteristic of that headache getting worse or coming on with those associations can also happen in brain tumor patients.
Thank you. It's very interesting. Patients often complain of headache after their brain tumor surgery. Are these expected to last?
Yes, that's a very good question. So after brain surgery, certainly in most cases, the pressure that was being built by the brain tumor is relieved. So why do people have headaches? Well, for the most part, it's headaches that are related more to the actual procedure than to the brain tumor itself. So it's very common for patients to have headaches that are centered around the incision of the scalp or around the bone that was cut to get access to the tumor. Interestingly enough, brain itself doesn't hurt. Brain doesn't have pain receptors, but those structures, the skin and the bone certainly do. That type of pain after surgery from the incision can last anywhere from days to weeks. So it's important to know that it can last a long time, because I know certainly for some patients, it's distressing having another headache that might be part of you might think is part of a brain tumor, but oftentimes has more to do with the procedure itself.
Thank you. It's very helpful information. You mentioned some of the other symptoms that might go along with a headache that might be cause for concern. Are there any other red flags that would be reason for a patient to call their doctor in the presence of a headache that you did not mention, or any other ones?
Absolutely. Again, like I mentioned, most headaches, even in brain tumor patients, are benign, right? So either related to the incision, or you might develop migraines and stuff like that. So when do you know when to call the doctor? I think one thing is, if you're having a headache that is progressively getting worse day to day over the span of days to weeks, that's a reason to call, right? Because it's most headaches that are benign come and go. Certainly anything that is accompanied by a new deficit, like I mentioned, weakness, numbness, trouble speaking, trouble walking, and then anything that has to do with losing or altering consciousness. If a patient with a brain tumor is also getting progressively either confused or losing consciousness or has a seizure, those are all reasons to call us to see if there's another reason behind the headache. The one thing I'll mention, it's not completely related to when to call, but certainly if, for example, you have a brain tumor diagnosis, you might have had surgery a few weeks ago, and you fall and you hit your head, and after that you have increasing headaches, just make sure to let us know that there's no trauma or bleeding in the area that we need to account for.
Great, thank you. Dr. Lee, another common complaint in patients with brain tumors are seizures. What is a seizure, and why are these common for our patients?
So seizure represents abnormal electrical activity in the brain. And so that causes that part of the brain to become more active. And sometimes that can manifest itself as, say, shaking of an arm or a leg, or unusual behaviors or unusual feelings. The reason why perhaps a brain tumor patient might have seizures, and not all brain tumor patients will have a seizure, but there is a higher risk of seizures in the brain tumor population. And that's mostly because the architecture of the brain has been disrupted by the tumor. So the electrical activity is not quite normal in that area. And as a result, people can be prone to having a seizure. And that is particularly dependent on where in the brain the abnormality exists, because there are certain parts of the brain that are more prone to seizing than other parts of the brain.
Can you tell us a little bit more about how we classify seizures?
So the simple way that we might classify seizures are to divide them into either focal seizures or generalized seizures. So focal seizures are seizures that started in one part of the brain and they stay in that one part of the brain. A generalized seizure is, as it sounds, could spread throughout the brain. So generally, and again, we're probably simplifying things for discussion purposes, with a focal seizure, as the name suggests, it's focal, it involves just that portion of the brain. Patients don't lose consciousness, and they might just have one particular presentation that, for example, just an arm shaking, right? While as a generalized seizure is probably what most people think of when they think of seizures, are seizures where you lose consciousness and there's generalized shaking throughout the body.
So what if somebody isn't experiencing any twitching or shaking? Could they still be having a focal seizure even without that movement?
Yes, absolutely. So there are different kinds of seizures, again, depending on what part of the brain is involved. So for example, seizures that emanate from a part of the brain that we call the temporal lobe can cause different kinds of seizures than perhaps what people are accustomed to. So people describe seizures where they might have a strange taste in their mouth that goes away, or they might have a strange smell, or they have a deja vu experience, or they have a strange rising sensation. I have a patient who described it as like a pit in their stomach. But what classifies these focal seizures is that you're doing well, like you're in your usual state of health. All of a sudden, something's very different. And it usually lasts a short period of time, 30, 60, 90 seconds, and it goes away on its own. So most seizures are quite short-lived, even though it might seem like a long time to a patient or a family member, they're actually short-lived. And once a patient develops a particular type of seizure, they tend to have the same kind of seizure. So they don't tend to have all kinds of different seizures. They tend to have one particular semiology or manifestation of their seizure, and that's the same kind of seizure that they have if that's the kind of seizure that they're developing.
Thank you. Very interesting. What should patients do if they start to experience a focal seizure or they think they may be having a focal seizure?
Well, if you've never had a focal seizure, if you've never had any kind of seizure, or you're just having an event and you're not sure what it is, of course, you would page your provider to discuss that. If there was anything scary about it, or you were just concerned, or you couldn't reach your provider, you would probably call 911 to go seek medical attention. There are some patients ultimately who know what their seizures are, that in discussion with their provider, there might be a shared decision to not necessarily have to go to the hospital for every seizure, especially if it's a very typical seizure and they know what their seizures are like. For example, with some of my patients who have very short-lived seizures and they occur only sporadically, we might prescribe a medication like lorazepam, which can help break the seizure. I would still ask that patient to call me to let me know that they've had a seizure. But then we can still manage some things, not necessarily have to rely on going to the hospital for management of seizures.
And how important would you say are seizure medications in helping prevent seizures from happening?
Well, we would consider them very important. we do want to, even if you just have focal seizures where you don't lose consciousness, we want to try to prevent the more serious seizures. So we do recommend that if you've had a seizure, you will need to be on a seizure medication to try to prevent further seizures. Obviously, we wouldn't want you to have a more serious seizure where you could potentially harm yourself, right? So we just want to make sure that you're safe and that the seizures are controlled, and the best way to control those seizures is with the seizure medications.
And what kind of side effects, if any, should patients expect from taking these medications?
All right, so there are lots of different seizure medications. Each seizure medication has a slightly different side effect profile, but some of the things that people across the board might describe from being on seizure medications is that maybe they feel a little bit sleepier from being on the seizure medications. Maybe they can't think quite as quickly as they did before. Maybe they feel a little bit more unsteady on their feet. But again, each seizure medication has a slightly different side effect profile.
And aside from being compliant with taking medications, are there any other things that patients can do to help prevent seizures?
So we know there are certain things that can lower the seizure threshold and make someone more prone to seizing. Examples of that are things like sleep deprivation. So we recommend patients with seizures to get good sleep. Missing doses of medication can certainly lower your seizure threshold, make you more prone to seizures. Serious infections can lower your seizure threshold. Of course, you can't always avoid all infections, but certainly you would want to minimize your risk of catching a bad infection if you can.
Thank you, Dr. Lee, for that very helpful overview. Really interesting. Dr. McFaline-Figueroa, earlier you had mentioned that confusion is a possible effect of a seizure. Are seizures the only cause of confusion in brain tumor patients, or do you see that in any other case?
Yes. So confusion can certainly happen in more than one scenario in brain tumor patients. And so seizures certainly, because of that disorganized electrical activity that kind of, short circuits the brain for a little bit of time, can cause confusion. But it's important to recognize too that when you have a brain tumor, your brain is working overtime to try to keep you working as normal as possible. And so sometimes when the brain is unable to compensate for that, you might develop symptoms such as confusion. We'll talk about this a little bit more later as well. But for example, the example I always give is, how some people get double vision when they're tired, right? And so that's just because your eyes are misaligned and then your brain is doing everything it can to keep it together, and sometimes it goes off, right? When you're too tired to compensate. So it can happen that if you have an infection, if you have not had enough sleep, if you have medications that are particularly sedating or altering, that your brain's just not able to compensate as well, and then patients might get confused. So it's not necessarily related to something like a seizure or tumor growth. There's actually many other reasons why it can happen.
So if somebody is experiencing confusion, let's say they're with their family and their family notices, what should they do?
So it often depends on the severity and the duration of the confusion, right? So like I mentioned, it's normal to fluctuate, particularly, being a little bit more confused towards the end of the day, because again, your brain is tired and it just can't keep up as much. But when it becomes more of a persistent and escalating issue, then that's the time to certainly call us and let us know that something more concerning is happening. So that's more about the duration of symptoms, right? If it's progressively getting worse and constant. If in terms of severity, certainly a little bit of confusion, I mentioned, is common to see. Like, for example, at the end of the day, you might not remember something specific but minor, or ask a question like, where am I right now? But it shouldn't be confusion to the point where you can't speak, you can't function, you can't interact. So if those things happen, that's another reason to contact us. Or if, frankly, if you feel unsafe, just contact 911 and then we can see what's happening.
So there are different degrees, and when it's a certain degree, it's a reason to get in contact with your doctor. Another complaint that we have in brain tumor patients is weakness. That was mentioned earlier. So that's an inability or reduced ability to move an arm or a leg. Sometimes it can make walking, for example, very difficult. What are some common causes of weakness in brain tumor patients?
Yeah. And so actually this follows, it pretty much is parallel to the confusion question. So same as your brain has to compensate and work overtime to keep you cognitively functioning the way you are, it's also working overtime. For example, if you initially had, for example, arm weakness that got better after treatment, and you're able to do most things, it still can happen that if, for example, you have an infection, you haven't slept too much, stuff like that, that suddenly that weakness is worse, right? And so I know that can be very distressing to patients or to the people around them, because it feels like it's happening all over again, right? When it's in the setting of infection or fatigue, then that usually gets better. The things to, again, pay a little bit more attention to is if it's weakness that is progressively getting worse day to day, right? That's no longer just a fluctuation of your brain compensating. It's just every single day is harder than the next. And certainly anything that comes on very quickly, if very suddenly you develop weakness, that would be another issue. And then lastly, just certainly seizures. If you have a focal seizure that, for example, cause your arm to convulse, to move, it's very common to then develop weakness after that for minutes or even an hour or two. So that's important to know.
Thank you. Very interesting. Before I ask you the next question, I just want to remind people as we're talking to please enter all your questions in the Q&A for when we're finished with the programmed questions. Dr. McFaline-Figueroa, what should a patient do if they develop acute weakness? So not something that comes on and gradually gets worse, but something that is, is very bad or extreme.
Yeah.
In one instance.
So when weakness comes on very suddenly, or actually, if any new deficit comes on very suddenly, weakness, suddenly unable to walk, suddenly unable to feel something, suddenly unable to speak, that always worries me that something related to either a seizure, which can come on quickly, or related to something to do with blood vessels. So stroke or bleeding can happen very quickly and develop symptoms very acutely. So it's my opinion that if anyone develops acute weakness, particularly something they've never felt before, that they come to the emergency department to get evaluated. Again, my main concerns are those things that we might need to manage, a stroke or bleeding when it's so severe and sudden.
Thank you. It's very helpful. So we got a question ahead of time that I wanted to bring up. Now we are going to open the discussion to any questions that people have right now. We got a question about diet. Is anything known about diet and brain tumor symptoms?
I'm happy to. So in terms of symptoms, certainly there's a lot of research out there about diets modifying the trajectory of some tumors. So you might have heard of ketogenic diets or clinical trials looking to see if that's helpful for certain type of tumors. That one in particular is quite involved and has very low caloric intake. I don't love it for patients who are getting chemo, because then you just lose too much weight. But there's a lot of research on that. The other thing that's can be complicated in terms of diet is one, always not so much for food itself, but sometimes for supplements that we take, making sure that you tell us so that nothing interacts with any of the medications that you're taking. And then lastly, certainly if, something that happened to one patient of mine actually was that every time she had diabetes and every time her blood sugar was really high, like I mentioned before, her weakness got worse and she found it very distressing. So things like, just to know that problems with nutrition or, sugar metabolism can affect the way you feel in terms of your brain tumor.
Thank you. We have another question in the chat that I'm going to read. Are there any factors, markers, or symptoms that can be identified to indicate the likely path of an oligodendroglioma grade 2 to whatever would be the next phase or the progression of the disease or the tumor? While I'm guessing every case might be different, are there any similarities that can be used to drive treatments?
Well, I think the main issue in terms of symptoms is that symptoms are so intimately tied to where in your brain the tumor is. So it's hard to say across the board that X, Y, and Z symptom is going to be a harbinger or going to tell you that something's happening with the tumor, because for every patient, it's different. Now, certainly if you have certain symptoms because of your brain tumor and those symptoms are getting worse and there isn't an alternate explanation, like Dr. McFaline-Figueroa said, where you're particularly fatigued or you have a severe infection or you just had a seizure, if there's no clear explanation that suggests that this is just a temporary reversible thing, then that is something to be perhaps more concerned about and to notify your provider about that happening. Because certainly if the tumor were growing, in theory, it would cause worsening of the symptoms that one is already experiencing. Seizures might be another indication. If you are a person who has very well-controlled seizures, and again, without an explanation like you missed doses of medications or you have a severe infection, all of a sudden you have really bad or poorly controlled seizures. Another reason perhaps to look to see if there's evidence of progression.
Thank
Well,
you.
I just want to add, I completely agree with Dr. Lee that in the brain, and this has a lot to do, even just thinking specifically about oligos, everything is location, location, location. And so you are correct in that that can alter how we do things. For example, if something is involving, has symptoms of speech difficulty because it's involving directly, the speech centers of the brain, then that's, for example, a path that of the oligo either initially diagnosed or as it's growing in an area that, for example, we might not be able to remove by surgery. So then you're thinking about treatments that are instead based on radiation or chemotherapies. So in that regard, it changes a lot our management based on the location. But for oligodendrogliomas, I would say that's the biggest factor. Otherwise, a lot of the other things are delineated pretty evenly across the board for patients.
Interesting. Thank you. We have a question here that may not be directly tied to the brain tumor symptoms topic, but I will ask one that might be, which is, does the blood-brain barrier impact treatments that you use for symptom management? The question here is about chemotherapy, but maybe we can think about it in terms of symptom management. Is that a factor? And are there some that are more effective, and why? And does it have to do with the blood-brain barrier?
Yeah, so certainly it is. It impacts a lot in terms of our treatments and availability of drugs to use. So the blood-brain barrier is a protection that your body has built in so that even if something really toxic is in your body, it doesn't affect your brain. So it's very much a very normal and very helpful thing that we have developed as a species. And then there are things that can cross the blood-brain barrier. So for example, you might ingest something that doesn't cross the blood-brain barrier at a high amount and then not have any confusion or any symptoms, but alcohol does cross the blood-brain barrier very well. So then you develop all these symptoms because it does so. And that is a very structural thing. So it's just that those blood vessels are made differently than they are in the rest of the body. The issue that we have is that some of our chemotherapies either do not cross it at all. And so, for example, we learned years ago that when patients with lung cancer were being treated with a certain type of inhibitor that didn't cross the brain, that their bodies did fantastic and then they developed brain tumors. And so that is one issue that needs to be overcome by making medications that are more specific, which now exists for that certain type of lung cancer. And then the second is that sometimes it gets in, but not enough. And so then we're dealing with the issue that we have to drive the dose of the chemotherapy higher and higher. And that may or may not be well tolerated, right? So it might get into the brain, but it might be too toxic for the body. So that's how it impacts our decision making. We need drugs that get in well and that do so at a dose that don't make you feel otherwise sick. Dr. Lee, do you have more to add?
Yeah, no, I totally agree. Now, with respect to the medications that we use for symptom management, I mean, we are already choosing medications that we know can get into the brain, right, and help. So when people have swelling because of their brain tumor, we give them steroids, which we know can get into the brain, right? We know the seizure medications that we use get into the brain. So a lot of the drugs that we use them because we know that they get into the brain. And I don't think that we would necessarily, there aren't like alternatives for symptom management that we generally consider or are limited because it doesn't get into the brain. Like there are already classes of drugs that have been developed for these symptoms because they help with the brain.
Great. Thank you, both of you. We have one other question in the chat. I'm interested in understanding the etiology of meningiomas. Why don't we talk about
so
that?
I wrote a little bit on the chat. So I guess bringing it back to symptoms, for example, so what are meningiomas? Meningiomas are tumors of the lining of the brain and spinal cord. So you have your skin, your scalp, your skull, and then the next layer is not directly brain, but this tough membrane that covers the entire brain and goes all the way down to the end of your spinal cord. So that's called dura. And meningiomas are just an overproliferation of those tumors of those cells that are in the dura. And that's a classic example of patients presenting either because of seizures, so the brain tumor that's developing touches and annoys the brain, or because of symptoms related to how big the mass is, because meningiomas can really push down onto the brain and cause headaches, nausea, vomiting, passing out, and stuff like that. And then deficits, depending on where they, like weakness, depending on where they push. We don't know a lot about what makes most brain tumors start. We do know that patients who have had really high doses of radiation to the brain many, many years ago are at a higher risk of meningioma and some other brain tumors. So that has something to do with how those arise. I mentioned that there's also a connection, we see more meningiomas in women, and they do express progesterone receptors, which is one of the reproductive hormones. So that might be why we see more in women. But that's not a lot more is coming to mind in terms of what we know. Most of the cases are just sporadic. Thankfully, most of the cases, well over 90%, are also benign. So sometimes it doesn't mean that you might not need treatment, but oftentimes treatment leads to long control.
Last question here in the chat. Is there a way to determine through imaging or any other means what particular nerves a tumor in the brain stem is impacting?
I don't know if we can get so sophisticated as to know which nerves specifically are being involved. I mean, we can tell by anatomy because we know where, which nerves live where and what function lives where in the brain. So there is a sense based on where in the brain it's located or where in the brainstem it's located. We can we can guess which nerves will be affected. But imaging wise, I'm not aware of that we can say, oh, this specific nerve is involved.
More based on the presentation or what we know about the brain.
Yeah, based on the location of what we're seeing on the scan and a knowledge of what lives at that location.
Right. Okay, great. Thank you. We actually have one more. How do you approach central nervous system neuropathy symptoms that do not respond to PNS treatments like SSRIs?
Yeah, so how do you approach pain in other parts of the body that's coming from brain injury, as opposed to pain in the peripheral nervous system, meaning pain in a particular body part because the nerve is affected? Honestly, we treat most of it very similarly because they do tend to respond to similar classes of medications. So you mentioned SSRIs, and certainly serotonin reuptake inhibitor, duloxetine is one that we use a lot for peripheral neuropathies that also has some effect in the brain. Things like gabapentin and Lyrica, I'm forgetting, pregabalin. So gabapentin, pregabalin, Lyrica, which again are good for peripheral neuropathies, tend to also be good for central neuropathic pain. And then sometimes if the neuropathic pain is related to swelling, then you can use steroids, although it's not very common for swelling to manifest as pain somewhere else. Dr. Lee, do you have any more?
No, there are older drugs as well as some of the tricyclic antidepressants. There are advances as well that I'm not as familiar about that is managed by the pain specialists as well.
And we do partner a lot with our colleagues in palliative medicine and who are experts at treating these types of pain. So it really is multidisciplinary how we try to approach this. And certainly some cases are easier or tougher than others in terms of getting the pain under control.
Great, thank you. Thank both of you, Dr. Lee and Dr. McFaline-Figueroa, for a great discussion on brain tumor symptoms. Are there any take-home points that you'd like to leave for the audience?
I would just like to, remind everybody that we're all human. We all have symptoms. We all have good days and bad days. So, I think something that creates a lot of stress and anxiety is thinking that every single thing that you feel every day could mean that the tumor is growing. And just try to, remember, okay, well, let me just see how it goes, because most headaches go away within an hour or minutes, and other symptoms that might be just because of fatigue or something like that. But then to really also know that we're always there. We're always there. If you have a question or concern, just pick up the phone. If we're not here ourselves and you're our patient, we do have fellows who are on for 24 hours a day. So we have somebody manning the phones at all times.
Great, thank you. Dr. Lee, anything to add?
No, thank you for the opportunity to participate in this. And hopefully people found it helpful.
Hope so too. So thank you everyone for attending. If you could please complete our survey, I'm going to paste it in the chat shortly. And then also make sure you register with the Neuro-Oncology Wellness Program to receive info about our upcoming activities. A link for the registration for the NOW program will also be in the chat. And also, July 18th is the date of our next NOW webinar with Dr. David Reardon, and he will be discussing standard and research therapies for glioblastoma. Thanks, everyone.
Thank you all so much. And just a reminder, this will be posted on our Blum YouTube playlist and Digital Resource Center. I will be sure to add the links into the YouTube description as well as the dates for the upcoming sessions. So you can check that out once it's posted, hopefully within the next few days or so. So stay tuned for that. And I wanted to thank you all again. This was a really great and interactive session, and the questions were all really well answered. So thank you all so much, and I will see you all next time.